drugs that affect blood, according to our topic says. So the drugs that affect blood are these different ones listed from number 2 to number 6. That's the drugs that can influence the way blood, the consistency of blood, all right? The way it flows, the consistency of blood, how healthy the blood of a human being is. These drugs can influence such. Oh no, this is not working. Okay. And then we saw our learning outcomes. Is that what we have now? Sure. So the learning outcome, this is what you should, the questions you should be able to answer you personally at the end of this class. You should be able to ask yourself, if I know the causes of anemia and the drugs that are used for the treatment of this diseases. Do you understand? You should be able to answer that question. You should be able to explain the mechanism of action and therapeutic uses of anticoagulation drugs that we're going to look at now. So at the end of this class, you should sit down and say, look, can I answer all of those questions? If I can answer all of those questions, then I've gained from this class. If I cannot, then I need to go back and read up to be able to answer all of this class. Because these are the aims and objectives of what's gathering here in this class today. Okay. So composition of the blood in mammals. Does anybody know what's going on here? And can they help me with this? Are you savvy? IT savvy? I thought you were coming out to help me. So you should be okay now. Thank you very much. Thank you so much. All right, sure. Thank you. So, you've seen the learning outcomes. That are just those days when everything is very wonderful. Okay. So I already mentioned the composition, that most of these drugs affect the composition of blood. All right. And what is the composition of blood? So we've done human biology, so you know what blood is composed of. You have plasma, and then you have the blood cells, basically. And so you're very familiar with this. So the blood cells consist of your red blood cells, your white blood cells, and the platelets. And these are produced by the hematopoietic system. All right? So the drugs that affect the blood, this topic can also be referred to as the drugs that affect the hematopoietic system. That's the system that produces the blood and its components, which is your plasma and the blood, the cells that you can see there. So the hematopoietic system, in addition to blood, has also the body organs and tissues, that help with making this blood cells. The spleen, the bone marrow, the thymus, and the lymph nodes are all part of this hematopoietic system. So when we talk about blood, it's not just about the plasma that is running in your veins. The hematopoietic system has also refers to where the cells are made. Like for instance, where is red blood cell made in the body? In the bone marrow. Where is it destroyed? In the spleen. Spleen. So the spleen is the final destination for red blood cells. All right. So we saw in the contents that we are going to look at different drugs that affect the blood in different ways. And the very first one we're going to look at are the anti-anemic drugs. Anti-anemic drugs, all right? Anemia, which means these are drugs that are used for the treatment of anemia. And what would you say is the definition of anemia? Pardon? Inadequate red blood cells and hemoglobin. So inadequate red blood cells and hemoglobin is what defines anemia. So someone is anemic if they have inadequate red blood cells and or hemoglobin. And this would be because they have lost a lot of blood, right? Either due to menstruation or some other causes that we'll see later. Menstruation, even your losses from the GIT when they have an ulcer or hemorrhoids that's bleeding, those are chronic causes of anemia. Also due to deficiency of nutrients. Have you done vitamins already? So you know the vitamins that help with blood production. Which are the vitamins that are important for blood production? Folic acid, and vitamin C, and B12. Thank you. So those are the vitamins. So if there's a deficiency of those vitamins, the person can become anemic. Or we said red blood cells are made in the bone marrow. If there is a depression of the bone marrow, the individual can also become anemic. Or increased destruction of red cells, which is called your hemolytic anemia. Like some conditions will cause red blood cells to be destroyed in the body, like we had a condition, sickle cell anemia. So sickle cell causes damage to red blood cells. In that condition, there is damage to red blood cells. All right. So we said the blood is made up of the red blood cell, the white blood cell, and the platelets. White blood cells are called what? And the platelets are called. So those two, from their names, are part of which system? They're also part of thrombocytes and leukocytes are part of the immune system. All right. So they're also part of that's why you have the lymph nodes being part of your hematopoietic system. So those are part of the immune system. But if we look at the red blood cell, let's focus on the red blood cell now. The red blood cell is made up of hemoglobin, all right? And it's an iron-rich red protein, okay? The red blood cell is made up of hemoglobin, and hemoglobin itself is an iron-rich red protein. So that's why red blood cells are red, because of hemoglobin, which is a red protein or a metalloprotein. And this iron-rich protein is responsible. So we said when blood circulates in the body, one of the importance of blood is to supply oxygen to the organs of the body. And this is because hemoglobin is responsible for the transportation of oxygen in the blood. And how does hemoglobin do it? Hemoglobin contains iron, like I said earlier, and that has 4 subunits, and oxygen can bind to the iron in hemoglobin. Okay? Oxygen binds to the iron in hemoglobin to form oxyhemoglobin. Okay? To form oxyhemoglobin. So that is how the blood is able to carry oxygen, because the red blood cells contain hemoglobin, which is an iron-rich red protein that oxygen can bind to form oxyhemoglobin. So when oxygen binds to this to the iron in hemoglobin, when it gets to the area where there is less pressure, it releases oxygen, and sometimes it picks up carbon dioxide. There are different. That's a different topic altogether. The transport of oxygen and carbon dioxide in the blood. So it picks up oxygen and binds to this to the iron in hemoglobin. Okay. So we already identified the last statement here that the production of red blood cells involves the presence of folic acid, B12, vitamin B12, vitamin C, okay, and B6 also. So if there's a deficiency of these vitamins, it could lead to anemia in the patient. So based on these different sources or factors that are required for the production of hemoglobin, there are different types of anemia. All right, there are different types of anemia, or based on the indices of red blood cell size, hemoglobin content, and then when you do examinations to check the red blood cell in an individual who is thought to be anemic, we can classify anemia into different types. And that will be your iron deficiency or hypochromic microcytic anemia. And iron deficiency microcytic or hypochromic. So hypochromic means that the color is is not as red as it should be. And then we have, so you understand, if you say someone has iron deficiency anemia, what rings a bell from your understanding of the composition of hemoglobin? So the hemoglobin, the red blood cells lack iron. Is that the M part of the red blood cell lacks iron, isn't it? So that's your iron deficiency anemia. Then you have your megaloblastic or macrocytic anemia, where you have the red blood cells being bigger than the usual size. So we said the types of anemia can be because of the size of a cell or the content of hemoglobin. Remember, the size of a cell, of the red blood cell, or the content of hemoglobin. And one anemia based on the content of hemoglobin is iron deficiency anemia. Another one based on the size is your megaloblastic anemia. Also with the iron deficiency microcytic, you would see that the red blood cells are smaller. So each of these terms would give you an idea of the presentation of that anemia. So you have it as iron deficiency, hypochromic, or microcytic, which means the cells are smaller than what it should normally be. Megaloblastic, the cells are bigger than what it would normally be. Then you have your aplastic anemia and erythropoietin deficiency anemia. Let's just quickly go to each of them. So we already talked about our iron deficiency anemia. Red blood cells are small, the color is pale, and it could be as a result of menstruation and all of those things that we saw there. Chronic blood loss as a result of hemorrhoids, gastric ulcers could also lead to what is called your iron deficiency anemia, or shortage of, take note of that, shortage of hydrochloric acid, HCl, hydrochloric acid, which is necessary for absorption of iron. Okay, hydrochloric acid, which is necessary for absorption of iron. If it is short, then iron cannot be absorbed. Okay, so that would lead to your iron deficiency anemia. So for this iron deficiency anemia, once you hear iron deficiency anemia, or once you confirm that the person has iron deficiency anemia, what should you do? If you wanted to treat it?
Iron supplements.
Give iron supplements, isn't it? That would be should be the next thing to do. But you need to make sure that you have excluded vitamin C deficiency in the person. Also excluded some carcinomas, some intestinal cancers, which could be responsible for the iron loss in the body. If there's no vitamin C, iron is not being converted. So even if you give the person iron supplements, what happens? It cannot be absorbed. You get it? So some underlying causes sometimes you need to find, because if you pump iron into the person, what's going to happen? You're going to have iron toxicity, because the iron is sitting in the blood, but it can't be taken in to do what you intended it to do, because there's no vitamin C present, or there is a carcinoma, or even there is gastric ulcer, and the patient is bleeding. So as you're pumping, even if it's been taken off, the person is still losing blood because the underlying condition has not been addressed. It's like you have a diabetic patient and they're very thirsty, and you keep giving them water to drink. Does that solve the problem? What do we need to treat the underlying cause? Treat the diabetes, and your patient will be better. And you don't even need to give them so much water afterwards. Alright. So as you rightly say, iron supplementation is the treatment for iron deficiency anemia. And iron supplements come as orals or oral preparations or parenteral presentation, or it comes combined with folic acid, and orals are cheaper and easier to use. Of course, parenteral preparations are preserved or reserved for emergencies or cases where it's impossible for the patient to use the oral, either because of oral preparations also have GIT disturbances, okay? And so that's one of the reasons why it will not be used. So parenteral preps will only be used if there is failure of the oral preparation, or the patient is just can't comply. It's like talking about when you talk about contraceptives, some women know that they cannot use the oral pills because they will never remember to take it every day. Let alone take it at the same time every day, which is the normal requirement for it to work excellently. You take it at the same time every day. So some people know they cannot, they will never remember. So if the patient is not complying, then you can give, and it's a case that needs iron supplementation, then we can give the parenteral ones. The combination ones can be used, folic acid can be combined with your ferrous. So in pregnancy, it comes in very handy. It can be combined with or some other things apart from folic acid. And so it can be used as a combination of more than one active ingredient. So what happens is that when you're using your iron supplements, it's important to check how the hemoglobin level is rising in the patient. And by 3 weeks, the patient should have improved to about 2 grams per milliliter from where they were before you started the treatment. Okay? So there should be an improvement in 3 weeks. You need to monitor the patient for that improvement. Also, it is advised that treatment is continued even for like 3 months, even after the patient has attained the required level of hemoglobin in the body, because iron is also stored in other parts of the body. So you want to make sure that you have it stored everywhere it needs to be stored, so you don't have the one in the blood being depleted because there's a shortage in any other part of the body. So you continue the treatment for longer than that, just to ensure that every part of the body that needs iron is well satisfied. So I already mentioned some of the adverse effects of iron supplementation. The very common one is a GIT effect, nausea, vomiting, and epigastric pain. Constipation is another side effect of using iron supplements. Dark stool. So patients complain that when they started iron supplements and then that stool is darkened. It's not something to worry about. It's just the iron supplements causing that. Also, sometimes you can have discoloration, particularly for children that use oral liquid preparations. So it can cause the teeth to get stained or discolored. And it's advised that iron tablets should not be chewed. Okay, it should be swallowed whole with a lot of water to ensure that the GIT effect is less, because if it's broken, then it's open in the stomach. Then it's to reduce to help manage the side effects. The patient can start with small doses of iron and then increase as the body gets used. Increase the dose as the body gets used to it, and then you take with meals to circumvent the nausea and vomiting. You take it with meals, all right? Although taking it with meals reduces the iron, but it's better to reduce it and give the patient the drug than have the patient stop taking it altogether because they're feeling nauseated or they're vomiting. Do you understand? So it's better to help the patient take it than for them to be frustrated because of those side effects. So I talked about iron poisoning earlier. Iron poisoning will lead to hemorrhagic gastroenteritis, and then you can have the patient vomiting blood, hematoemesis, okay, and sometimes diarrhea, shock, serious complications like hypoglycemia, acidosis, and all of that, and even death can occur with toxicity of iron. So it's something that we need to check to make sure that the patient needs before we administer to the patient. So if we have toxicity of iron, the antidote that can be used for that is a desferrioxamine, okay, which is an iron chelating agent. Then we have megaloblastic anemia. That means megaloblastic. You have larger than normal sized red blood cells, okay, but they're immature. They're not very mature. They cannot actually carry out the functions of the blood very well, and dysfunctional. Okay, they are immature and dysfunctional as they're produced in the bone marrow as a result of this anemia. And what is the cause of megaloblastic anemia? Is the deficiency of B12 or folic acid. So the deficiency of B12 or folic acid will lead to megaloblastic anemia, while we saw iron deficiency anemia earlier. So because megaloblastic anemia can be caused by the deficiency of vitamin B12 or folic acid, under megaloblastic anemia we can classify the deficiency under these two elements that are required for it. So we would have vitamin B12 deficiency anemia. Okay, it can be caused by either B12 or folic acid, or both of them together. So we can have the deficiency being either vitamin B12 deficiency anemia, or what's the other one? Folic acid deficiency anemia. Do you understand it? So megaloblastic anemia can be, the deficiency can be classed under those two headings. Okay. So how do we know if someone has vitamin B12 deficiency anemia? They will present with neurologic disorders, or when we check, usually what needs to be done is that the blood sample is taken, and then you want to check, microscopically check what the red blood cells look like, to actually be able to tell what kind of anemia the patient is presenting with. Okay? If the patient has anemia, what are the clinical signs that you would see? Paleness, tiredness, what else? Dizziness, fatigue, you get tired very easily, all right? So those are the clinical symptoms or presentations or anemia generally. But how do you tell which medications to give them? Whether it's iron, whether it's B12, whether it's folic acid? You can only determine if you check the blood to see what the red blood cells look like. Okay, so your vitamin B12 B12 is absorbed. So vitamin B12 deficiency anemia, that means there is a lack of B12 in the body, all right? And B12 is usually gotten from diet, especially meat. Is absorbed from meat by an intrinsic factor that is in the GI mucosa. So the deficiency of this intrinsic factor, I'm sure you're familiar with intrinsic factors from human biology, your coagulation factors, and all of those things. Do you remember all of those things? We'll still do them soon. So the absence of this intrinsic factor will result in, because that is what helps with the absorption of vitamin B12, will lead to the deficiency of B12 in the body. All right, and this B12, this intrinsic factor, there can be a deficiency if the patient has a gastric bypass. Remember that the intrinsic factor is in the GIT. So if there's been any disturbance of the GIT, it can affect the availability of the intrinsic factor. That's why you would have the gastric bypass, gastrosectomy, small bowel diseases will cause megaloblastic anemia. Am I making sense to you? Because absorption of B12 is aided by the intrinsic factor in the GIT mucosa. If the GIT mucosa has been in any way, the integrity has been altered or any other thing has been done to it through either gastric bypass, gastrectomy, or bowel diseases, it can affect the availability of the intrinsic factor, and then you would have B12 anemia. So, but we can address this issue by giving parenteral vitamin B12 preparations, which is cyanocobalamin, either IM or SC. That's subcutaneous or intramuscular. So your folic acid deficiency anemia, let me see. So your B12 anemia is called your pernicious anemia. The folic acid is called the macrocytic anemia. Macrocytic anemia, which is where you will find the big. So how does a folic acid deficiency anemia occur? Definitely because of a deficiency in folic acid, isn't it? Definitely because of a deficiency in folic acid. And what occurs deficiency in folic acid? Insufficient consumption or absorption of folic acid, okay? So folic acid deficit would lead to folic acid deficiency anemia. Insufficient intake. Alcohol, when you eat vitamins, you'd have seen that alcohol would affect the absorption of folic acid. Pregnancy, lactation, they all affect the availability of folic acid. Why? Pregnancy, lactation, why would they affect the availability of folic acid? Alcohol affects the absorption. These ones do not affect the absorption, they affect the availability of folic acid to other parts of the body, for other functions in the body. Why? Pardon? Pardon? Why is folic acid needed in pregnancy? Tell me.
Everything, I mean, this usually development in your body, so everything changes.
Pardon?
There's a big change happening in your body.
In the body.
Yeah.
So, alright, so we see that one of the functions of folic acid is synthesis of DNA. Okay, synthesis of DNA. Folic acid plays a role in synthesis of DNA. And when someone is pregnant, what's happening? There is a human being formed in the tummy. Okay? So we need a lot of DNA, we need all of this to be formed. And we need a neural tube defect as due to the deficiency of folic acid. So the body naturally tries to avoid the development of such. And so it takes folic acid from every other source and concentrates it in the pregnancy. Do you understand? So the woman will feel the woman is deficient because there is not enough for her and the baby. And the body naturally prioritizes the baby over the mother in pregnancy. Do you understand? The body naturally prioritizes the baby, the formation of the baby, the health of the baby over that of the mother in pregnancy. So it pulls all of those to ensure that the baby is formed normally. So that's why the mother needs to be encouraged to take folic acid and any other minerals and vitamins that she needs, because the body will pull it from wherever you can find it. Okay, and so there are also some drugs with antifolic activity. These drugs inhibit folic acid synthesis, and we saw one of them during our last lecture, methotrexate for rheumatoid arthritis. Remember that we said methotrexate is an antifolate. So when the patient is on methotrexate, which is used for rheumatoid arthritis, you also want to give them folic acid to use at the same time because it inhibits, that's going back to the last lecture, we can tie everything together. It inhibits the synthesis of folic acid. Trimethoprim and sulfasalazine is also, there are also other examples of such. So the toxicity of from methotrexate can be treated with folinic acid. The next anemia is your aplastic anemia. So here what happens is that the body stops producing enough new blood cells. Now this is not just talking about red blood cells. It stops producing all the blood cells altogether, the white one, the red one, what other color? The platelets, not color. So it stops producing enough new blood cells because the bone marrow is damaged. Okay, because of damage to the bone marrow, and the bone marrow may be damaged as a result of a drug therapy, like in cancer chemotherapy, some insecticides, and even chloramphenicol can be used. So for the treatment of aplastic anemia, we use anabolic steroids. Erythropoietin deficiency anemia. Erythropoietin is produced by the kidney, and it helps to stimulate bone marrow. Treatment if there is that anemia, what you need to give is your epoetin alpha or beta to treat it. So this anemia would usually occur when the patient has chronic renal failure. Alright. So we just looked at drugs that can be used for the treatment of anemia. Please let me know what time it is. I don't have the time. Can you just let me 10 to 12. Okay. When it's 12:30, please when is this class over? 1, isn't it? When it's 12, just let me know. Thank you. So drugs that affect the blood. The next drug that affects the blood that we're going to look at are called are drugs that affect blood coagulation. Blood coagulation. Alright? And this group of drugs are referred to as your anticoagulants, antiplatelets, fibrinolytics, and antithrombotics. Those are the different the groups of drugs that are under drugs that affect coagulation, blood coagulation. Under drugs that affect blood coagulation, we have your anticoagulants, antiplatelets, fibrinolytics, and antithrombotics. Okay. So when we're going now, we're going to be looking at this different. So don't get lost. Stay with me as we're going. blood coagulation all about? When we talk about, I usually like to ask, you've done hemostasis or hemodynamics. Have you done hemodynamics? First year. What is hemodynamics? What is hemostasis?
Stopping the blood hemorrhage. The process you end up stopping it.
See, she remembered. So to stop hemorrhage. Yeah, blood loss. Thank you very much. So that is hemostasis. Hemostasis is a process that ensures that blood continues to be in a fluid, clot-free state. Alright? We know blood flow is laminar. Blood flows through the vessels. Alright? And the body does not want to lose any of the blood that's going through it. And it doesn't want the blood, if the blood gets, what's coagulation? First thing you need to start with that coagulation. What does coagulation mean? Clotting. It's clumping together, isn't it? Clumping together. Rather than being fluid, becoming semi-solid or solid. Okay, isn't it? Rather than being free-flowing, becoming a semi-solid or having some pulling together of the blood. But we don't know if blood comes together or pulls together or clots. What happens to blood flow? What would happen to blood flow? Through our arteries and veins. Huh? It's reduced. It's going to be not just reduced, it's not going to be consistent. Okay? It's going to be reduced, and then you have it's going to be impeded by the clots and the clumps that you find in the body. But we want to ensure that blood is flowing freely as a fluid through the body. So the process of hemostasis ensures that blood is not clumped together, and peradventure there is a break in the vessel or an artery that it is immediately clogged, so that there is no blood loss. That's the process of hemostasis. The peradventure there is a break in the vessel or an artery. The hemostatic process is quickly put in place to stop blood loss, okay? To stop blood loss, so that the volume of blood in the body does not reduce unnecessarily. When the volume of blood in the body reduces, or you have high blood loss, what happens to the patient? What are the possible things that could happen to the patient? Anemia, shock. The patient could go into shock. Alright? The patient becomes anemic. Alright, so the body tries to ensure that this doesn't happen. Okay, so while the body is trying to ensure that if there is a break in the vessel or in the artery, that we quickly sort it out, have it plugged so that we can stop hemorrhage. Some other situation can arise where there is, what should we say now? So let me take it from here. So in the hemostatic process, you've done hemostasis. So you know what happens in hemostasis when there is a break in the vessel. So hemostasis is about the integrity of the blood vessel. Are we agreeing with me? It's about the blood vessel, ensuring that it stays intact the way it is and the blood can flow through it without any interruption. So if there is a break in the vessel, the process that's put in place is that there is the vascular wall. The process of inflammation process is elicited. Are we together? Okay? So there is the vascular stage. Vascular component is released. Platelets are released to the side of the injury as well. Okay? And we have your coagulation cascade also being released there to ensure that the break in the vessel is plugged, is healed, and blood flow through that vessel is stopped. Okay, so we have the vascular component, we have platelets, and we have the all coagulation cascade. This you did in human biology. Am I correct? Okay. So this is what normally would happen. Are you familiar with this picture from human biology? Are you familiar with this picture? So we have the vascular phase, then we have the platelets phase, and we have the coagulation phase to ensure that the break in the vessel is healed and is plugged, that blood flow stops. In some instances, it could happen. So for this, we have all of these phases and the fibrinolytic phases now. In some cases, you could have, in the absence of an injury, there might not be a serious injury, or it could be a minor injury in the vessel. This process is also elicited. All right? The process is elicited. But what it forms is called a thrombus. It forms a blood clot that is now called a thrombus. In either a vessel that is not injured or a vessel that has a minor injury. And then it forms the process that this cascade that you saw now, the vascular phase, the platelet phase, the coagulation phase, like you would do for when a vessel is broken, also that process is elicited and it forms what is referred to as a blood clot, which now becomes a problem in the vessel. It forms a blood clot, which now becomes a problem in the vessel because blood cannot flow freely because of the presence of the blood clot. So that process of forming a blood clot in uninjured vessels or vessels with minor injury through the same process that we saw, that the hemostatic process that we saw, forms what is called, the blood clot is called a thrombus. That unwanted, undesirable blood clot in that part of the vessel is called a thrombus. And this hinders the flow, the free flow of blood through the vessel. Not only does it hinder the free flow of blood through the vessel, sometimes it becomes dislodged. Remember, I don't want to go through that process because you're supposed to be very familiar with it. Remember that the platelet, when after the vascular phase, have the platelet being released, the platelets aggregates, isn't it? And then what happens after the platelet aggregates? You have the coagulation phase, and in the coagulation phase and the fibrinolytic phase, you have fibrin being deposited on the platelets to make them more solid. So fibrinogen is converted to insoluble fibrin that makes the plug. In normal hemostasis is called a plug, but in thrombosis it's called a clot. Remember, it's a plug in normal hemostasis. And then you have your fibrinolytic phase where that occurs. All right. So if that happens, there was no injury and we have a blood clot being formed, like I was saying earlier. So it not only hinders the flow of blood through the vessels, it also sometimes breaks off. Okay? It breaks off from the site where it was formed and flows through in the blood to other parts of the body. And it can become an emboli. So that is where your thromboembolisms come from. Your pulmonary embolism comes as a result of clots that is formed in the vessel that breaks off and travels in the blood to other parts of the body. So it becomes an emboli, and with the clot you can have your myocardial infarction because of the inhibition of blood flow in the body. So So thrombosis can occur either in the arteries or in the veins. In the arteries, you will find your myocardial infarction, which is a disruption of ischemic necrosis, which means there is not enough blood supply. And it could occur in the vein. When it happens in a vein, it usually causes edema and inflammation, like your deep vein thrombosis. So when we say a thrombosis, it means that a clot is formed that is inhibiting or hindering blood flow in that part of the body. Or an emboli, a clot that has traveled from one part of the body to another to become a nuisance. Like you would have with in the vein, where there is deep vein, in the deep veins, your deep vein thrombosis, I don't know if you've done that in your clinical nursing, deep vein thrombosis can dislodge to become a pulmonary emboli. So that's why you have deep vein thrombosis is a condition that is well monitored because the clot can dislodge and go and lodge in the lungs to become pulmonary embolism. Okay? So embolism is not just about the clot, it could be gas that's traveling in the body and inhibiting blood flow, or some other kind of solid, or the thrombus, like you said, that dislodged and travels to inhibit blood flow in the body. So the drugs that affect blood coagulation are drugs that try to ensure that unnecessary blood clots are not formed in the vessels of the blood. Okay? Unnecessary blood clots are not formed in the vessels of the blood. I don't know if you did in your hemostasis where you see the vessels have some properties, naturally have some properties that ensure that the platelets do not aggregate together. So these properties ensure that blood keeps flowing freely. Platelets do not aggregate together, which will form a blood clot. And the cell walls have heparin-like substances that keeps the blood flowing freely. We'll see heparin, but I'm sure you've heard about heparin. It's an anticoagulant. So heparin-like substances are naturally present in vessels to ensure that blood doesn't thicken or coagulate and it keeps flowing. So when you find a blood vessel that has lost these properties, then it is easy. So they become pro-thrombotic. They become pro-thrombotic because they've lost this natural ability that they have to prevent thrombosis, platelet coagulation, and the heparin-like substances that prevent blood from getting congealing. Yes, prevents blood from getting congealed. So those kind of vessels become pro-thrombotic. So if a person has a pro-thrombotic condition, then they would need to use the drugs that prevent your anticoagulants that would help them prevent the formation of clots in the body. Because we said with the arteries, we have myocardial infarction, deep vein thrombosis, pulmonary embolisms, and these are very, they are conditions that need monitoring if a patient has them. Yes. So let's see the different anticoagulants. So heparin and warfarin are very popular for the prophylaxis and treatment of this thrombosis. So we understand what the cause of venous thrombosis and arterial thrombosis. Do we get it from the explanation from hemostasis and hemodynamics? That it can happen if the vessel loses its ability to be, instead of being, what's the opposite of pro-thrombotic? What would be the other one? Once again, it's huh? Tell me, I can't remember. So pro means they support thrombosis. If it doesn't support thrombosis, what term can we use for it? Pro-thrombotic and, okay, I don't know. If I remember along the way, I was going to. But you were saying something. Tell me, remind me. If it's against it, huh? Oh, no, not necessarily proactivist and all of those terms that we use every day. Okay, when we remember it. Anybody that remembers, please tell me. Okay, so heparin or warfarin are used for the treatment of thrombosis. But heparin and warfarin are anticoagulants, remember. So they prevent the coagulation cascade of the body. Are you looking it up? Okay. Okay, so the heparin and warfarin are mainly used for venous thrombosis. They are not used for arterial thrombosis. They're used for venous thrombosis, not arterial thrombosis. Because for arterial thrombosis, you need to be able to stop platelet aggregation. And heparin and warfarin do not have the ability, or they have very little inconsequential ability to stop platelet aggregation. Which drug has the ability to stop platelet aggregation? None of the drugs. No, apart from warfarin and heparin. No, warfarin, I just said now that heparin and warfarin do not have the ability to stop platelet aggregation. They can stop thrombus formation, not platelet aggregation. That's why we don't use them in arterial thrombosis. So which other drug has, which drug, not which other drug? I think my question is wrong. When I say which other, it means which drug has the ability to stop platelet aggregation? Aspirin. Thank you very much. Aspirin, like we saw when we looked at our non-steroidal anti-inflammatory agents. So aspirin will be of good use in arterial thrombus formation. So heparin has the three different classes of heparin. It could be unfractionated, low molecular weight, or the anticoagulants are heparin and warfarin. Heparin presents as, or it's formulated as your unfractionated heparin or the low molecular weight heparin, while you have warfarin as a vitamin K antagonist. So warfarin is a vitamin K antagonist. Heparin is not an oral preparation. Okay, it's used parenterally. It's formed. So there is, I was saying earlier, that some heparin-like substances are in the vessels to help blood, to help stop blood from coagulating. And you will see here that it's formed and stored in the cells of the tissues. So heparin is a natural product that is available. So it is not used orally because it is inactivated as when it's taken orally. It is inactivated when it is taken orally. So that's why it is used parenterally. You know the different routes of administration. It's used parenterally. So what it does, the mechanism of action, is to directly act on anticoagulation. Directly stop. So your coagulation cascade, let me see, I was supposed to have it here. Our coagulation cascade, our normal hemostatic processes like we have here, heparin directly acts on one of these processes to stop thrombus formation. Remember that thrombus formation is the same as your normal hemostatic process. You remember, but it's just not, there wasn't a reason for it. It just happened. And we don't want it. That's what makes it, that's why we are stopping it. But it's the same as we are getting your hemostatic plug. So heparin would act directly to, on that process to stop coagulation, okay? And its effect is, its action is immediate. So once heparin is administered, you will see the reason why, because warfarin takes up to 3 days before it starts acting. But heparin, so take note of the similarities and differences between heparin and warfarin. We'll get there now. The similarities and differences between heparin and warfarin, you have it somewhere in your textbook. So as I'm talking, I'll try and compare them. If you don't have a textbook, you can just take it down and take note of that. So, so the effect of heparin is immediate, but it's very brief. It's very short acting. So if there is an emergency and you need an anticoagulant, then heparin will be your drug of choice. So what it does, the mechanism of action is that it accelerates the action of antithrombin 3. Antithrombin 3 is where now? So you would see here, prothrombin is converted to thrombin in our coagulation phase. Thrombin acts on fibrinogen and converts it to fibrin. Okay? Fibrin is what causes your fibrin clot, the insoluble part of the fibrin clot. Then you have plasminogen being converted to plasmin to break down the fibrin clot. Antithrombin 3 is here. It acts on thrombin 3A's ability to convert fibrinogen to fibrin. Remember your coagulation cascade, as you can see there, the hemostatic stages. When prothrombin is converted to thrombin, then you have fibrin being deposited on the platelets. Do you remember? On the platelets, insoluble fibrin, to make it a more firmer plug. To make your plug more firmer, the fibrin is deposited there. If antithrombin 3 can stop prothrombin from becoming thrombin, then it cuts off that process at that point. Do you get it? So fibrinogen is not converted to fibrin, and the plug is not solid. There is no deposition of fibrin on it that will make it solid. Do we understand it? There is no deposition of fibrin on the platelets that will make the plug solid. And so the clot can be dispersed in that way. If it is not solid, then it's easy for it to break up and go. So that is what heparin does. It accelerates the activity of antithrombin 3 to inhibit various clotting factors, elimination of that. So heparin prevents the conversion of prothrombin to fibrin and fibrinogen to fibrin monomer. It also prevents the formation of platelet plug, like I said, that binds with fibrin to form a thrombus plug through the action of thrombin. So that's like if you have an injury, like normally if you have an injury even on the body, that's the same, you have the same process, usually taking place. That fibrin is not added on to make it a solid clot. So, in conclusion, heparin suppresses the action of thrombin. Heparin suppresses the action of thrombin. So it is used for preventing formation of venous thrombosis, or if there is already a thrombi, to prevent it from getting bigger. Okay, to prevent it from getting bigger, and it's safe in pregnancy, but should not be used for pregnant. Obstetric bleeding may occur. So the pregnant woman that needs to take heparin needs to be monitored. Platelet counts should be done for them. So it can be given as full IV doses depending on the condition, or it can be given as low subcutaneous doses, or it can be used in vitro. In vitro means externally. In vivo, in the body, in vitro, externally. So we are nurses, if you take a blood sample, and keep it on the table, what happens? It clots. So usually your tube, your test tube, or your specimen bottle must have an anticoagulant, and heparin is used in that instance. So that's the in vitro. Once you say test, vitro test tube, in vitro use of heparin. So I said heparin is there unfractionated or low molecular weights. The low molecular weights and the unfractionated, the difference between the two is not It's just as effective as your unfractionated. It can be used for the same conditions. It has longer half-life and all of those. So what are the adverse effects of heparin? Heparin increases the risk of hemorrhage. Okay, so if you thin the blood, if you stop coagulation, if someone is on heparin and they have a cut, they have an accident, what would happen to them? Excessive bleeding. So if someone is on an anticoagulant, and we saw also with aspirin, because of this antiplatelet activity, that it can cause hemorrhage. Because the blood, it will take time for the clotting factor to have an effect because of the anticoagulation effect of the medication. So it takes a longer time. So the patient bleeds more. And sometimes you might need to introduce some coagulation factors to stop the bleeding. So that's the primary risk of heparin. Another thing that is osteoporosis, and with osteoporosis, of course, you know spontaneous fraction usually comes, especially when they've been using the medication for a long time, and all the other things. Hypersensitivity reaction is another adverse effect of heparin. So if a patient has had an overdose of heparin, sulfate is the drug of choice if there is an overdose of heparin. It's contraindicated in eye, brain, or spinal cord surgeries. Warfarin. So we say heparin is used parenterally because why is it used parenterally? It is inactivated orally. It's inactivated when it is used orally. That means it cannot perform. It cannot reach its therapeutic purpose.
So you're saying it should be given orally?
It should not be given orally because it is inactivated. It should only be given parenterally, where you can go. It doesn't have to go through the GI tip. It can go straight into the bloodstream.
I've seen it being given orally.
Heparin. Are you sure it wasn't?
Oh no, this.
Are you here? No, heparin. I'm just comparing. Now I'm comparing heparin and warfarin.
Okay.
So I said heparin we saw should be given parenterally. Warfarin is given orally. Are we together now? Okay. So warfarin is given orally, and it's from the sweet clover, and it used to be used for. So we say it's an anticoagulant. It was used as a rodenticide, for killing rodents. How would it work if it's an anticoagulant? It blocks. So what does it do to the rodents? Okay. So mechanism of action. We saw heparin was directly acting on the anticoagulation phase. Okay. Now bringing my comparison between heparin and warfarin into focus. We saw heparin acts directly on anticoagulation. Now we see warfarin is indirect acting. Okay, it acts indirectly. It's for oral use. Okay, heparin acts on antichromatin 3. Warfarin acts on vitamin K. It's a vitamin K analog. Okay. So what it does is to interfere with the synthesis of vitamin K. And if we look at the clotting factor. The clotting factor, what's the role of vitamin K in the clotting factor? Anybody remember? Huh? What is it? Vitamin K. So vitamin K, do you remember? Or you quickly go to the vitamins page in your textbook and tell me, so that we can learn it now. Someone quickly go to the vitamins page. Vitamin K, let's see what it does, and how it works in clotting. What do you want to say? I think vitamins is which page? Chapter 11. How does vitamin K function in blood clotting? Can we find it? Or we go and research it? She doesn't say anything about that. And you can't remember from your human biology. Okay, Google this. It just talks about okay, so what should Google be? Okay, so it's a very, very long story. Okay, so vitamin K is, you guys remember your clotting factor and all of that. It's very essential to form a blood clot. So that's why you would say warfarin is acting indirectly. Remember with heparin, we could see the action of heparin in the coagulation phase on this protein 3. So, but we don't see vitamin K in this cascade that we're looking at. And that is what makes warfarin and indirectly acting. It's acting on something that is participating in the process. It's not acting directly in the in coagulation, anticoagulation. So it also interferes with synthesis of clotting factors that are vitamin K dependent in the liver. I already told you earlier that one of the differences between heparin and warfarin is that onset of action of warfarin takes 3 days. So what it means that if a patient is going to be placed on warfarin, they need to start with heparin as well. Otherwise, in those first 3 days, what happens to the patient? They don't get any therapeutic effect from the drug. So they usually start combining with warfarin to first start off the process, and then after 3 days, they can continue with warfarin.
They say warfarin is a vitamin K antagonist.
Yes.
And the day they say vitamin K analog. So one they say antagonist and another one say analog of vitamin K. So
The warfarin is it here?
it's
So warfarin is a vitamin. Remember, it inhibits the synthesis. It interferes with the synthesis of vitamin K.
So it's antagonist.
That is why it is called an antagonist. So this agonism and antagonism, something that if it disturbs the pharmacological effect of a drug, then it is an antagonist of that drug. If it supports or mimics the pharmacological effect of a drug, then it's an agonist because it's helping that. But if it's doing an opposite, you know the different kinds of antagonism and agonism.
Also, you mean it can act in both ways?
No. I'm just explaining the different. What it does is to interfere with the synthesis of vitamin K. So it's Okay. What's the time?
8 minutes past 12.
Past 12. Okay, let's see later we'll discuss. Okay. So what's confusing you is the analog and the antagonist. Can you just check it out now so that we can finish this class today? Where were we? So it interferes with synthesis of prothrombin from. Okay, this is the way. So it interferes with synthesis of prothrombin from vitamin K in the liver. Okay, so an antagonist, what does an antagonist do? It replaces the action or opposes the action of the drug. It's a competitive antagonist. So wherever it says vitamin K, it displaces vitamin K. It's competitive. It's as in whenever the two of them are together, there is a big fight, and warfarin wins because it has more affinity for. So it replaces vitamin K in that process. That's why it interferes with the synthesis of prothrombin from vitamin K in the liver. Okay. Remember, we have prothrombin being converted to thrombin in our hemostasis chart. Prothrombin being converted to thrombin. So warfarin interferes with the synthesis of prothrombin itself. Okay, prothrombin being converted to thrombin. Warfarin interferes with the synthesis of this prothrombin. Yeah, I just wanted to know how far I would have gone by now. Okay, so let's race. 30 minutes more to go. Definitely, like heparin, it's used for prevention of your thrombotic conditions. So can warfarin be used for emergency situations?
No.
Why not?
The
Onset of action. The word is the onset of action of warfarin. It takes slow. It takes 3 days. So it cannot be used for emergency. Also with heparin, there is a test that needed to be done. That's partial prothrombin test to check to see, because these drugs also have what is known as a narrow therapeutic index. Have we ever heard that? The narrow therapeutic index. So they need to be monitored. They're not drugs, even paracetamol has adverse effects. So they're not drugs you just pump into a person and just let them go. If you give just a little dose above what is required, can cause problems for the patient. Okay? And lead to toxicity. So they need to be monitored. So what happens is that, so they need to check with heparin. Heparin will require a PPT to be done. This is warfarin. Heparin requires a PPT to be done, particularly for the high dose, for the full IV dosages. Okay, you want to check if the coagulation that you desire has been reached with the dose that is currently in the blood. So if you have desirable anticoagulation, you don't want to give more of the medication. So you just check to see how effective is the dose that you're giving. If the dose you're giving now, the PPT is effective, then you don't give more. You just, because you don't want to cause too much anticoagulation even at that. You don't want the person to start bleeding through their eyes or their nose because of anticoagulation. So you monitor it. Warfarin also requires monitoring, either with the prothrombin, the PT, or the INR. the international is this where we were? Okay, so therapeutic uses. So you want to monitor the use of warfarin as well, using either the PT or the INR to ensure that, to know when to stop dosing the patient, to know when the dose you've given is giving the required therapeutic effect, so you don't go beyond what is necessary and endanger the life. Remember, the very the narrow therapeutic index of the drugs. All right. So adverse effect also is hemorrhage, epistaxis, bleeding through the nose, occurs with warfarin, gum bleeding in patients that are using it, or excessive menstruation. If the patient presents with any of this, bleeding through the nose, gum bleeding, so it is advised that the drug should be stopped in such a patient. Right? The drug should be stopped, withdraw, and then give a vitamin K analog to help induce the clotting factor, so the patient's blood can clot. If it's severe, then you give the patient all blood. All blood contains the whole clotting factor, so the patient can get that immediately. Warfarin also interacts with a lot of drugs. It may be displaced by aspirin. So if it may be displaced by aspirin, aspirin is more strongly bound, more protein, it's more strongly plasma protein bound compared to warfarin. So if you give a patient warfarin and aspirin, warfarin will be displaced by aspirin. Okay? And so you would have, what's going to happen to warfarin? You have a lot of warfarin in the blood. And what's going to happen with the toxicity of warfarin? We have. So you want to be careful in this case. Then it increases, aspirin inhibits platelet adhesiveness. So also you don't want to give warfarin and aspirin together. That's question mark there. You don't want to give warfarin and aspirin together because warfarin is an anticoagulant that inhibits coagulation, and aspirin does what? Inhibits platelet aggregation. So when you give both of them together, what happens? A synergy occurs, and there is more anticoagulation, and the patient is at higher risk. Unlike aspirin, it doesn't, if you give them together because of the increased risk of gastric hemorrhage. So read up the differences between heparin and warfarin. It's in your textbook, page 243. Another group of drugs that affect blood coagulation are referred to as antiplatelet drugs. And that one we won't spend time on it because we already know aspirin is a typical example of our antiplatelet drugs. And what it does is to reduce platelet aggregation, or platelet adhesiveness. So this one, remember when there is an injury, when there is a break in the vessel, the platelets go there and they clump together. Platelets are deposited at the side of the injury and they clump together. Alright? So what aspirin does is to ensure that they are not able to be coercive. That adhesiveness is prevented by aspirin. So the initial formation of the clot is stopped when the patient is on aspirin. Unlike with heparin and warfarin that will act on the clot, aspirin does not even allow the clot to form because the platelets cannot even come together and form a gang that will cause any problem. Do you understand? They can't come together and cause any problem. So the dose of aspirin will be 75 to 150 milligram. And so there are different types of antiplatelet drugs mentioned there: aspirin, clopidogrel, prasugrel, and all of those. You can read through that. Another group is your fibrinolytic drugs. If we look at our cascade, I didn't have it. Fibrinolytic phase was the last phase in our cascade. Human biology again. What happened in the fibrinolytic phase? The breakdown of fibrin by plasmine. Plasminogen? By plasmine. So plasminogen is converted to plasmine, which now helps to break down the fibrin clot or the hemostatic plug that was formed. So your fibrinolytic drugs help to dissolve newly formed thrombi. Newly formed thrombi can be dissolved using, so it needs to be newly formed. If it is already polymerized fibrin, remember fibrin is deposited on your platelets to polymerize them to make them stronger. So if it's a new clot, fibrinogen will be able to dissolve the clots, the thrombus. But if it's already hardened and polymerized, it really doesn't have any effect. So it needs to be used early in the patient. Okay. So it also causes hemorrhage. It causes hypersensitivity reaction as well. Those are the disadvantages. If you look at the advantages and disadvantages. And it needs to be initiated. So I said earlier that it needs to be used early because it will only act on freshly formed or newly formed thrombi. So it needs to be used within the 6 hours of the event. Within the first, in MI, myocardial infarction, so a patient that presents with myocardial infarction, fibrinolytic drugs must be given within the first 6 hours of that presentation. Because it won't work once the thrombus is polymerized. Another class is your antithrombic drugs, like the ones that I mentioned, the dabigatran, rivaroxaban, and anagrelin. Okay, so we just saw drugs that act on coagulation, that help to prevent the blood from clotting, that helps to prevent thrombuses being formed in blood or blood clots being formed in vessels rather. So another class of drugs is called your hemostatic drugs. Hemostatic drugs. Very familiar term, we've been using it all day. So they prevent hemorrhage. They prevent hemorrhage, and they do this either systematically or locally. They can be used systematically, or they can be used. And then when they go for surgeries as well, you need an hemostatic drug because they bleed easily. You need to help them stop bleeding. So that's why you see tranexamic acid being used for either during surgical or non-surgical treatment of hemorrhage of the bladder, or for hemophilia during surgery or even dental extraction. Will make them bleed so much that you need to introduce an hemostatic drug. So this acts opposite to your anticoagulants. Hemostatic drugs induce coagulation. Anticoagulants prevent coagulation. Okay? So it can be used locally as well. So if topically you have adrenaline to help bleeding. Absorbable gelatin sponge can be applied to surgical sites to stop capillary bleeding. Okay, it can be left in the wound to stop the capillary bleeding, and you don't have to wait for the natural clotting process to come in. You want to ensure the patient doesn't lose too much blood, so you introduce an hemostatic drug to quickly stop bleeding in such cases of surgery. Okay, the fifth group of drugs that affect the blood is plasma substitute and colloidal solutions. These ones are called blood expanders. Particularly if a patient has lost blood, a lot of blood, they're in shock, or they've had a burn, or they're about to go into shock or something like that, and you want to increase blood volume. then you give them this plasma substitutes and colloidal solutions. So they are basically IV preparations. They are not taken orally. So they are used to restore volume, blood volume, in patients. And examples are your pentastarch, tetrastarch, human albumin, and all of that. The last group of drugs that we're going to look at today is drugs that affect the blood, cholesterol and triglyceride reducers. So cholesterol and triglyceride reducers. So hyperlipoproteinemia. It's a long one. So hyperlipoproteinemia. So that's talking about. So it's let's break it down. High lipoprotein anemia, blood. So high incidences of lipids in the blood. And proteins in the blood. So what are the lipids and proteins in the blood? Cholesterol and triglycerides, isn't it? Your lipoproteins are cholesterol and triglycerides. So when you have a hyperlipoproteinemia means the combination of hypercholesterolemia and hypertriglyceridemia. Okay, so it combines both of them together. When you read the text, you see a lot of hyper this and hyper that. Just do that. So they cause coronary vessel disease. When you have hyper of your lipoproteins in the blood, it causes your coronary vessel disease. An example is your atherosclerosis. And it can be managed by lifestyle. So here, hyperlipoproteinemia could be genetic. Okay? So it could be because someone comes from a family where they have that genetic factor, where they are just naturally predisposed to having a high level of these proteins, or lipoproteins in the blood. Or it could be as a result of the other conditions that are mentioned there. It could be as a result of lifestyle and diet. Sedentary lifestyle and eating a lot of food that's converted to cholesterol. All fowls, high oily food and all of that that's converted to cholesterol in the body. So cholesterol, we have 3 different types of cholesterol: LDL, VLDL, and HDL. We all know the good one and the bad one, so let's always stand with that one. Maybe we can go on orange. Yes. Okay. But I want to take note of transports. HDL transports cholesterol from the peripheral tissue to the liver for excretion. So that's one of the advantages of HDL. Also take note of, in your textbook, there is a side note that talks about the desired amount of HDL and LDL in males and females. Take note of that. Okay? Here it says total cholesterol reading of above 6.5 millimole per liter requires a lipoprotein profile to be done on the patient. So if it's over that amount, you want to know what each of those, remember lipoproteins are cholesterol and triglycerides. So you want to do a lipoprotein profile to see what each of them counts for, your HDL or your LDL and triglycerides. So you know which one is high, because we desire to have a higher level of HDL and a lower level of LDL. Tell me from your textbook the prescribed level of HDL and LDL. It's on one of the sides there. This is the baby. Is it here? Look here, let me see. Tell me if you find it. I'm going to ask this question, so just take very long. Let's talk about it now. The LDL is desired to be less than 1.0. Is it 1.0? 1.2?
It's 1.0 for men.
For men, and for women?
It's 1.2.
Oh, 1.2 for women. So, LDL, please look at the page.
Page 248.
Page 248. On the side of page 248. Alright? Page 248. It is desired that LDL be lower in the body. Because LDL transports cholesterol in plasma. LDL is the one that carries a lot of cholesterol in plasma. So your low density lipoprotein cholesterol is your LDL. And your VLDL contains large quantities of triglycerides. But HDL contains only 20% of cholesterol and 30% of phospholipids. Also, in addition, HDL transports cholesterol from the peripheral tissue to the liver for excretion. So HDL helps with the metabolism and excretion of cholesterol. And that's what we want to higher. So you would see there, we desire LDL to be less than 1.04 mils, 1.2 for females, and then LDL, what's our desire? It must be above 3. It must be above 3 for both male and female. So you see, so we want more HDL and less LDL. HDL must be above 3, LDL must be below 1, because of these advantages that we have seen so far. So what's the value for the total cholesterol? And that's what's so once total cholesterol is above 5, okay, the patient needs to take caution. But treatment doesn't need to be instituted immediately. The patient can start with lifestyle changes and watch the diet. And if that is not working, then we can recommend pharmacotherapy for the patient. And the drugs that are used for hypercholesteremia and hyperglyceridemia are your statins, nicotine acid derivatives, fibrates, and some other ones that are in your textbook. All right. And then I think I have the mechanism of action of statins here. They inhibit MGGO reductase, which is involved in cholesterol synthesis. Okay, they inhibit an enzyme involved in cholesterol synthesis. And usually it's advised that they should be taken at night because cholesterol synthesis usually takes place at night. And the statins are the drug of choice, and they are also cost effective. So you can read the others, and that would be it. Thank you very much. I'm as tired as you are. So any other questions as per your, because you won't be in class tomorrow, as per the tests?